Very interesting charts, interesting things. We will discuss these things with two economists from Switzerland. But let me first ask you, first of all, Jacob, you told your reforms went through Parliament without any, without the big discussions, without any changes. Don't you have lobbyists in Denmark and stakeholders who are lobbying for their direct interests?
Well, an expert committee doesn't really work in isolation. It works in they can see what is realistic, what's the political appetite for change, and so in many ways when you make these expert committees, well, in theory you're of course completely isolated, but you also see what is possible in the current situation. And in this situation there was and we have a majority government that is quite unusual. We have a government who wanted to make change, so that gave bigger opportunities than it was normally happening. And then we actually had the doctors' organizations in general really embracing that we need to do something, otherwise they will be in trouble also, because we have the demographic change. So there's also some willingness to actually change something. But I think the key thing in our reform is that it's the first time for many years that we have a majority government who's actually able to make the changes they intend to do. It's not that they go through Parliament only with the majority government; they also include other parties. But there is a and then there is the thing that Kjell mentioned, that if you start messing around with one of the reform, then it will have implications for what you can do, and then you basically say this is the package for all the underlying detailed technicalities, and then we decide whether there should be 1, 2, or 3 or 5 regions, and they settled on 4, and it doesn't really matter much.
And I think also with Jacob's commission, actually they were supposed to travel across the country. They were supposed to have meetings with the parties. So actually they traveled across the country. When we did the hospital reform, I think we visited, almost true, we visited all hospitals. And it was just to show we know what we're talking about, because obviously they were thinking those are just people sitting in the offices in Copenhagen, not knowing anything about how things work in reality. And that was not the case, and that was not the case when we did the hospital reform.
Yeah, exactly. So most of the time for the Commission was actually spent on meeting the healthcare system all over the country, so we have a common idea what is the burning platform and why do we actually need to change.
A question on the hospital reform. You closed 17 hospitals. You never had local initiatives of citizens demonstrating, we don't close this hospital, or even before your house, Professor Peterson is the closing man of hospitals and destroying our healthcare system?
No, actually, because an amazing change of minds occurred, I think, around the turn of the millennium, actually, where the population basically at last started realizing that it's not necessarily a blessing to have a small, incompetent hospital around the corner, as opposed to having a more specialized hospital that is far away. So actually, we did not have that. I have had the experience as a CEO of a county health service in the late 80s, and they could collect ridiculous signatures on signatures protesting. But actually, that gradually changed. There was an understanding that good quality requires more specialization, more centralization.
So the quality transparency was the key to change this mindset?
Yeah, not even necessarily transparency, but just simply realizing you get better treatment. We have good examples of cancer treatment where actually cancer surgery was carried out in about 30 hospitals with dismal survival results.
Okay.
And that was centralized to about 5 or 6 hospitals, and actually that improved quality in terms of survival.
That of course requires some data, and I think that the change in the mindset was when we saw the dismal cancer survival rates, And that also led to bigger discussion about what is quality and how do we actually achieve quality, and you need to have bigger hospitals to achieve better quality. And that mindset was taken by especially the unions for the doctors. They acknowledged that this is how it is, and it also diffused into the population that this understanding that you might want a local a hospital to work at or to supply services to create of the community, but if you're sick yourself, you don't really want to go there.
Of course. We will discuss this now with two economists from Switzerland. Mr. Professor Stefan Felder, he's the director of the Health Economics Department at the University of Basel. Please stay on the scene. And Professor Emeritus Robert Loy, you all know him from the University of Bern. Come on over here, please. Zwei rein. Ja. So, you as healthcare economists and experts here in Switzerland, so when you saw these data, these developments, these reforms, what was the point where you thought, oh, that's interesting, I never thought about that? Did you had such a kind of a...
I think what was most unbelievable to me was the process. I mean, these guys, you know, nice and friendly guys, we know each other since about 25 years, and they just write up their expertise, and they go to the government, and the government goes to parliament, and then it's passed just one by one. I've never heard that in my life.
What was your impression? Yeah.
I calculated the hospitals we need in Switzerland, given the Danish level, right? So we have about 100 acute hospitals, and we would need only 30, right? So we should close 70 hospitals in Switzerland. Yeah. So this is the Danish level, and it's not going to work, right? We are different, as you indicated. But as you heard, right, data requirement is very important. And I don't know, Andreas quoted ANQ this morning, right? So we have information, and so this is certainly the beginning to inform people about the quality in individual hospitals. So yes, the need to close hospital, that is what was my first.
Yeah. Yes. You said it's not going to happen here, but we have a transition from hospital care to general practitioners, like in Denmark, and the costs of the hospital are going up every year. The deficits, and the cantons have to pay it, or they pay it. So at the end of the day, maybe the question is, do we still pay for these 100 acute hospitals, or will the pressure go so up that at the end we will have to close, maybe not 70, but 50?
The question is when it's going to happen, right?
Yeah.
Maybe in 10 years' time or so. But the cost.
They needed 18 years as well, as Mr. Pedersen said. So. And
right, I mean the costs are increasing there, and you diminish the 50%, right, from 3% GDP to 2% acute care. This is amazing, right? And we are just going on. And well, I don't know what you want to say about that. It's just unbelievable, right?
But if you think about it now, so we have about 100 hospitals, and they are pretty full. Now, if we close 70 hospitals, where do the patients go? Because like the university hospitals and so on, they are also full, pretty full. And we still do not have the outpatient kind of capacities as you do. But where did your patients go?
Yeah.
Well, first of all, length of stay is important. So also we have a record in short lengths of stay. And that means usually cases that is sufficient. That's one way. And as you indicated, then we had a lot of discussion about substitution of inpatient care for outpatient. And when we planned this whole thing about the hospital structure, we had long discussions about how could we make sure that substitution took place. so that you move treatment into outpatient treatment. And basically, and this is a crude way of saying, you do that by closing beds, because then you're just forcing them to think in terms of elective surgery, in terms of outpatient. And that was essentially, it sounds crude, but still, it's really amounted to that.
Yeah. So now that we have EFAS, we can do that and move patients to outpatient care, do elective surgery just in daily surgery. And our length of stay is also coming down, but it's about 2 days more than it is in Denmark.
You never had a discussion on a stay that is too short, that people have to go out of the hospital without having had the treatment they needed? A scandalization?
No, really, it's believed that they get the necessary treatment.
At home.
Also, I just should add a little bit, because actually some of the patients basically go back to municipalities where they get home help and home nursing situations. So actually, it's not simple as that. It's not only a question of moving into outpatient treatment, but actually also make sure that they are going back after discharge to the municipalities for further treatment or further nursing, really.
Jacob?
Yes.
Yeah, and it's just to point out that when you go down that route, and we have gone down quite far on that route because we have a very high degree of day surgery, I think, together with US, and we have the highest number, and we also got the lowest inpatient capacity. But to move that development even further, you need to have a close link with the nursing in the municipalities, the elderly care, and that's why we're having this reform right now, that we have to think that you cannot just reduce and push more and more out of the hospitals if you do not build up some capacity for caring especially the elderly with multiple chronic diseases within their own home.
So this is the approach of our health minister, to think about the broad thing, not just hospitals and general practitioners, but also nursing and physiotherapy and so on. Yeah.
Yeah, we should also understand that we have ambulatory care in hospital in Switzerland. So this sector is rather large, right? And so we can move that out of the inpatient part and then have more connection to nurses and other professionals. I think it's not only about closing the hospitals, but just bring them to another structure, and that will help out. That will help to make the transition.
Maybe, yeah.
And that was what we have done. We have moved very much of our capacity from inpatient to outpatient care in the hospital. But what we need now is to move that activity from the hospital to the GP and surrounded by the network of specialists in the GP books. When we see the number of elderly, we will see that we will have difficulties by keeping all these patients in the hospitals while still maintaining a very highly specialized hospital. And we need the university hospitals to only deal with the very specialized treatment, and then we need to take care of what we can take care of in the community.
Yeah, I think we all agree that we can close certain hospitals, but I think we cannot do it to the same extent as you did it. I mean, region is different here. We have 4 languages, that makes a difference. And I think especially the expectations are different. People are not ready to go on waiting lists here. Yeah, it's apparently the premiums are not yet so high that people are ready to go on waiting lists.
Yeah.
Well, in terms of waiting lists, just to address that, we have what we call a patient right in Denmark, meaning that if you had waited for surgery at a public hospital, for instance, hip replacement, and you waited more than 30 days, then you gain the right to go to a private hospital, paid out of the public coffers. So actually, it's not long waiting lists like, for instance, in England.
Yeah.
There is a waiting time, but actually, if you did not have it, then you probably had an oversupply of beds. So that's another part of it, of the picture. And also, I should just add, actually, when we started this process of reforming the hospital structure, we started in this expert panel by cutting the number of beds with 25%. And the region said that is not possible. We said we had calculations showing that you can move that to outpatient, and it turned out that they did that, and did that even more dramatically than we had expected.
Okay. Yeah.
And we've done quite a few of regression analysis and on the capacity, and so can we see any relationship with the inpatients, number of inpatient stay or overcapacity in the wards and the number of beds, and you can really see no correlation. If you have a bed, there'll be a patient in the bed.
Okay.
If you take away the bed, then
that's
there'll be no patient.
That's in the healthcare sector always the case, yes.
Yeah. I mean, it's interesting we have co-payment in Switzerland, which is not, you said yesterday that suicidal, right? You cannot have it there. But we have co-payment, and also, I mean, that maybe we're going to increase the deductible from 300 to 500, and I think that will also help a little bit. So you can either have waiting time or you go through co-payment, and that will help a little bit decreasing the demand for consultation that are not really needed, right?
Maybe another thing, you told that there was a strong hand, the experts and or the government. We lack a strong hand in Switzerland. We usually work with incentives. Did you never consider or have incentives not be a thing in your reforms, or did you work with both of them?
There are lots of incentives in the reform. It's an incentive to have a job. So if you want to be a doctor and cannot be employed in a big city and still want to be a doctor, then there's incentive to move to a smaller city.
Yeah.
It's just not a financial incentive.
That's a very existential incentive. Yeah.
But we don't force anybody. We basically use the labor market. Yeah. Supply and demand, okay. And that's how economy works.
I know that
economy works, Robert.
Stefan just mentioned co-payments, and I know that not everybody in here is in favor of co-payments. But there is so much evidence in the literature that if you have co-payments, that reduces moral hazard on the demand side. Right, there is also supply side moral hazard, but on the demand side. But I know our health minister is not so really favorable for co-payments, right? Yes.
Okay, maybe let's move to digitalization, because this will be a huge topic in Switzerland for the next. It already is, but it will be even bigger thing in the next years. What are your impressions on what Denmark did on digitalization?
I mean, this is very impressive, of course, right? I mean, they have the default is that you are in the system, and we have discussion that people can opt out here in Switzerland, and the comment was quite clear: it's not going to work here, right? So and I always think somehow people here think we are still in a private system, but no, we have social health insurance since 30 years, and that should imply something. So I would like to see more competence from the federal level when it comes to EPD, and we don't have that. We are very reluctant, and that's why it's not going to work. But it works in Denmark, and also for us scientists it would be very important. You also point to the fact that research is very important there, right? Yeah. And to merge the different data sources. Yeah. That's all possible in that system. And here in Switzerland, it's very, very difficult to merge data from different sources. So
but it's interesting. The systems are private, but they are certified by the state, as I learned. It's just the duty of the state is to say, okay, this system will work with all the other systems, so it is approved, then take it or leave it. Can you maybe tell us more about this certification, because this is very interesting to merge all the different systems that are existing in a healthcare system.
Well, basically, it's not really a question of certification. What is important is that you have systems that can talk across the systems.
Yeah.
For instance, if you have two hospital file systems, you simply need to make sure that they can communicate across the systems. And we have written protocols for that, has been developed that actually by a small company that actually is subcontracting these protocols to other companies. So actually... But
still a private company that does that.
The systems are privately run, but actually paid by the public.
Okay.
So that's run by, if there is, the regions, if we take that example. But still, they have been developed and they have been maintained by private companies.
Robert, is this a pathway for the electronic patients?
Well, I think definitely this is an example how you can introduce such an electronic patient dossier. of course, there are other countries in the world who have done that at the same time, all the Nordic countries, all the Baltic countries, and others also. So I think it would be worthwhile to look how these countries have introduced their systems. We have now one system here, how they did it. I don't know whether we can do it exactly in the same way, but basically, you know, we economists, we tend to think we have an invisible hand, but
they have a strong hand.
Some of us have thought
your hand.
In this respect, we need a visible hand and a strong visible hand, just to make sure that everybody participates, yeah, and that there is, of course, there must be an opt-out option, yeah. You have an opt-out possibility. Nobody uses it, but you have the possibility. And in our system, we have an opt-in. And we all know if you have to opt in, just few people will opt in. But once you are all in the system, very few people will opt out. So there is certainly one issue that there's a lot of learnings.
So I would like to give you the opt-in option and ask some questions or make some remarks on what we've heard now. Is there a mic? Yeah, well, there's a microphone. Who would like to ask something? Nobody. Are you all? Oh, over there? Over there.
I'm wondering, you were talking about the hospital information systems and the primary care systems that they're from private companies and so on. But who is sort of running and purchasing and taking care of the sort of nationwide systems like Gesundheitswesen and the systems you mentioned?
That's taken care of by a national organization. If you take Gesundheitswesen, that's essentially run by the public sector. It's a joint undertaking by central government and the regions. So they do that. So that's a national initiative, as is, say, the app for the general practitioners. That's also run nationally. So actually just taps into the individual systems. So you do need, we just joked about the invisible hand and then the visible hand. And actually, in these cases, you need a visible hand. You also need a visible hand actually to tell people that if they're not following suit on digitalizing patient records, they simply have to, otherwise probably will withdraw funding.
Okay.
Thank you.
Over there, the lady.
Well, thank you. We've heard previous that you think our system won't work like that. Can you explain us, please?
I think the key here is that you need courage of data. If you only got 1%, or maybe you can work, it'll get up to 5% or even 10% or 15% over a long time period, then nobody will ever use the system. It'll be an auxiliary to the paper system. If you want to get rid of the paper, you basically need 90-something% using the system. So therefore, you have to have an opt-out instead of an opt-in, because it will simply take too long to have everybody to opt in. And nobody sees the advantages in the beginning, because when you only have a few percentages opting in, you don't have the app like we have. You don't have a schedule of, then you haven't got the message service with the GP. You cannot see what medicine you're on in the prescription medicine. When you have full coverage, you can see the advantages of the system, and you don't really want to opt out.
Okay, there's the lady over there.
If I understood right, you told us that one key point of your system at the beginning, that you went around the whole country and talked to all specialists who work at the front and asked what would be the best for the patient. Is that right? So actually, I think I'm missing that in Switzerland. Maybe we should do that.
Great point.
Well, just to say that the traveling thing and the traveling shows, as we call it, actually is try to mindset people to say what is going to happen and why. And then also, and you're indicating that, avoid saying that this is just being decided in a small office in Bern. Actually, it's important to say we were there, we saw it, we discussed it with you.
So it was not only a strong hand, it was also a strong and convincing arguments followed by a head. Okay. Over there?
I guess in Switzerland we don't only need a strong hand, right? I mean, we also need to really take the population along. And I'm still a bit curious about this mindset change or this burning platform in 2007, how it was really created, right? Because I mean, we always end up in a vote, and our politicians really do tend to go along what the common consensus is of beliefs in the population. So what situation was there exactly in the early 2000s? How did this mindset change happen, and what kind of data helped it? How was it publicized in the media? How was it played? And is there something that we could actually even learn or do differently? What would be your recommendation to actually drive this mindset shift in the Swiss population?
I don't think you can boil it down to one or two things, but
make it four.
But if we go back to the 70s or when I was a child, there was no discussion in the world that we lived in the best country in the world with the best healthcare, exactly like you live in the best country in the world with the best healthcare. Data, lack of it was a blessing. And then we had an underfunded hospital system in many ways, at least for uptake of new technologies. And then it became clearer and clearer from the media debate that it was not the case. We are not having the best healthcare system in the world. And when we look more and more into the data, it was actually a very poor healthcare system in many ways, and performing poorly, not performing according to the ideas of the population and the politicians. And then they started to do different reforms, and then at some point Lars Løkke Rasmussen, our current Minister of Foreign Affairs, he had a strong belief that the structural changes were needed. So it's also about having the right mindset of strong politicians together with a burning platform, and that came down the route that we need structural changes. And within the structural changes, we all got new funding, all new hospitals, and now we're developing in a different path. But so it's a long way of understanding that what we actually believed in when we were children was not true, and when we had strong and visionary politicians that actually had the courage to do something about it.
Robert or Stefan, do you see a path to a similar a change of mindset in Switzerland? What should change? What we need?
Well, I think it became clear. What we need is data, and we need to know the quality of different institutions and different providers. And I think that's the main driver, as you told me, when it became clear that cancer mortality was so high that people started to understand that we need a change. Do we want to be killers and have a hospital around the corner, or do we want to have hospitals farther away but more specialized? I think that was the crucial issue. And people started to understand that. That is a quality issue. And I think Swiss people would understand that too. But for that, they need data, and they need the information about qualities, about outcome qualities, right? So.
But I think we have some data in Switzerland as well. But most politicians, they start their discourses with, our healthcare system is the best of the world, as Jakob said. Maybe this is not as honest as it should be.
Well, again, we have A and Q, right? And yes. So information is there. Maybe we can discuss about the quality of that. But what strikes me a bit as strange is that this is financed by public money, right? And we don't have access to that. So, I mean, the information is there, and it could be really brought
discussed in a broader way
to the people, but that's not the case. And I think here the policy could step in and make this information public, and I think that would be a first start with regard to hospital care
quality. Yeah. Other questions over here? Up.
Yes, thank you. I just wanted a few additional thoughts about this notion of quality transparency, because the notion seems to be that we need to expose or embarrass, so to speak, those who provide less good quality, or at least that could be a misunderstanding if someone talks about quality transparency. And to avoid this misunderstanding, maybe I wanted to ask you if you could reflect on that question.
We have to be careful not to overdo the issue of transparency. But if we look at hospital quality, then essentially we are running about 90 databases on quality for separate diagnoses. So actually you're pulling in quality data from the patient records into the quality databases. That means, for instance, if you take hip replacement, which has been mentioned earlier, then we can simply, and that is analyzed, and then you have what are called standards. Are you meeting standards? That is, how often do you need a new surgery to redo the hip replacement? How often is so-and-so complication getting into it? And that is available at the hospital and the departmental level. Never really at the physician level, because that's a separate issue. Then also, just adding to that, whether that's transparency or not, then we're also carrying out patient satisfaction surveys, and that has been done since the turn of the millennium, actually, where you ask people a lot of questions about how satisfied with the inpatient, with the outpatient services, and it's really amazing, and it really amazes me, about 90% says that they were satisfied or very satisfied, actually even in view of some of the public expressed dissatisfaction. So at the end of the day, population or patients actually think it's reasonably well.
Jacob?
Well, again, you stated it, we shouldn't overdo the transparency in the sense that patients hardly never go into these quality data and look at them. So this is, they're available, but they don't use them. They prefer to go to the local hospital and believe that this is that the hospitals are actually performing well, and somebody else looks at it. And somebody else actually looks at these data.
Ooh.
And now we have the regents, in the regents individual, and then we have in the end the National Board of Health if there are quality concerns, and then it's their responsibility to deal with it. Yeah.
I think that is a disadvantage in Denmark, because you have just one payer, right? Whereas in Switzerland we have many insurance companies, and I think it would be a responsibility for the sickness fund to come in and make quality a parameter for contracts. And there I think we have an advantage. You don't have free contracting, whereas here in Switzerland it's basically possible in alternative model. Yes. We could include quality information and make that part of a contract between the insurance company and a group of GPs or hospitals. Yeah.
Some over there.
I would be interesting in the personnel. How did you get enough people in the healthcare system? And could you save people when you closed hospital and make bigger ones? And you don't have too much immigration, and you seem to have enough personnel, or haven't you?
Well, you will never have enough personnel in the healthcare sector. The healthcare sector will only be satisfied when they use 3 times the GDP. So it's also a political discussion about how much do we want to spend and how much can you how many want to employ. Well, university training is free in Denmark, and it's very prestigious to go to medical school. So we're a lot of, and far too many goes to medical school. I think it's 3% goes to medical school from the university level, and so we have an oversupply. What we have an undersupply is of course nurse assistants, because it's not as prestigious, so we have to deal with some of the incentives there. It's not that well paid, so we're also looking into that. But I think it's fair to say, and you can correct me, that this merger of the hospitals were not from a saving perspective, it was a quality program. So we didn't save much by merging the hospitals. That being said, it would have not been possible to have the staff to provide the services that the National Board of Health required to have an open acute and emergency hospital, because then it's basically stated that 25/7, 21 different specialities need to be available. So in that sense, it was not possible with the staff to continue to have smaller hospitals with the higher requirements on quality. So in that sense, it was a natural thing that happened, but to begin with, it was never ever a saving exercise or cost-cutting exercise. Even concerning the personnel, it was not about saving cost, it was about improving quality. And if you need to improve the quality, then you need to merge. That was basically the idea. And I think, as economists, looking back, I think some of our hospitals have become too big. Some of them have staff with over 10,000 people full-time equivalent, and that makes them difficult to run efficiently. So I think we have to do something slightly different. I think we'll have a little less focus on having so many university hospitals, but you can comment on that.
No, I agree entirely. In that work we did on this expert panel, we didn't really discuss hospital size, even despite that I personally do not think that the big university hospitals have a good size. I prefer hospitals with about 400 to 600 beds and not with 1,000 beds, because actually you have disadvantage of running big university hospitals. But now we have them and we're trying to get the best out of it.
So please, Robert, what do you learn from Denmark as kind of a closing argument after we need some quality time as well and have a coffee break, I think?
Okay, there are definitely a few issues where we can profit a lot. I think you have heard most of them. There are also other issues where we think we would stay with what we have, like co-payments, for example. And I think we don't have to start by reducing the number of hospitals so much. We could just increase the number of cases per surgeon or per surgical team, and that would increase quality.
Okay, thank you very much, Kjeld, Jakob, Stefan and Robert, for these interesting discussions, and I'm clear that there will be more time to discuss this directly with those interesting people.